Good day. I'm Jason Karlawish, speaking to you from my office at the University of Pennsylvania, where I'm on faculty in the School of Medicine. I'm a physician trained in geriatric medicine. I co-direct the Penn Memory Center. I'm part of the leadership of our National Institute of Aging funded Alzheimer's Disease Research Center, and I do research focused on ethical, legal, and social issues in the lives of older adults living with disabling cognitive impairments. Obviously, a lot of my research focuses on persons living with Alzheimer's disease. I see patients at the Penn Memory Center every week, in addition to my research work. The title of my talk is Thinking Outside the Boxes, and I hope by the end of my talk, this somewhat provocative and at the same time enigmatic title will become quite clear to you. If you'd like to learn more about who I am and the research and work and writing that I do, you can visit my website there. It's just my name, jasonkarlawish.com. And if you're a Twitter user, I'm occasionally on Twitter, and by all means, you can check me out and such. Sometimes a drug doesn't simply treat a disease. Sometimes a drug also changes the ways we think and so talk about a disease. And I would argue that the drug lecanemab is one of these revolutionary kind of drugs. Now, assuming that U.S. regulatory agencies charged with drug approval, namely the FDA, and charged with reimbursement for drugs in Medicare, namely the Center for Medicare and Medicaid Services, assuming those two regulatory agencies conclude that the results of the Clarity trial of lecanemab in persons with Alzheimer's disease, that those results are good enough to approve the drug and to pay for prescriptions, then my patients who have mild cognitive impairment or mild stage dementia will have an entirely novel conversations with me about treating Alzheimer's disease. For one thing, we'll start talking about biomarkers, particularly testing for markers of beta amyloid, one of the two pathologies that are implicated in Alzheimer's disease. And if their beta amyloid test is positive or elevated, the option to take a drug that slows Alzheimer's disease. But what does it mean to slow Alzheimer's disease? Is slowing this disease a benefit? Well, at the same time that Clarity has the Alzheimer's disease field looking very far forward with great hope and promise, these same questions have us looking backwards, back to the late 20th century, when there were hot debates in the field over the clinical meaningfulness of the benefits of the drugs that were under the category of what were called cholinesterase inhibitors. Those drugs such as donepezil and galantamine and rivastigmine, etc., were drugs that were debated about their ability, the significance of their improvement on metric measures of cognition and function. Were those improvements in cognition and function sufficiently large enough to justify those drugs' risks, hassles, and, before they went generic, their costs? I would submit that lecanemab instigates very similar conversations, but now those conversations have an intense moral inflection, and I think they really ought to. Because unlike the cholinesterase inhibitors, lecanemab doesn't improve a patient's function. It doesn't. The study results of the Clarity study are very convincing of a different effect, namely that lecanemab decelerates the progressive disabilities that persons living with mild cognitive impairment or mild stage dementia experience as a result of progressive neurodegeneration. It also has risks. It risks microscopic brain bleeds and areas of small swelling in the very same organ that it's designed to treat. Microscopic bleeds in the brain and small areas of fluid collection in the brain. So is this balance of risks and benefits worth taking? And it's a very novel conversation of risk and benefit, because prior to lecanemab, my colleagues and I did not have a drug that we could prescribe with confidence that we could say that it was making a difference in the disease pathology, the process that affects patients. Well, because of the understandable and appropriate attention that's been paid to the drug, even before it's become available in clinical practice, I've already started having conversations with my patients and their family members about this question of, is this drug worth its risks and benefits? And at first, my conversations were really focused on Clarity's primary endpoint, called the sum of boxes on the Clinical Dementia Rating, or abbreviated the CDR sum of boxes. CDR for Clinical Dementia Rating, sum of boxes for a peculiar way to look at this common but rarely applied scale in clinical practice. But, the more I tried to talk about this quirky measure and the quirky, deeper interpretation of this measure, the more I struggled. And I think that's understandable, because outside of the clinical research community, the CDR is essentially unknown. There are several hundred people right now on this webinar. Have any of you heard of the CDR? When any of you talk about your Alzheimer's disease or your relative's Alzheimer's disease or Alzheimer's disease in general, do you talk about the CDR? And if you do, perhaps, do you talk about the CDR sum of boxes? I would submit you don't. I would submit that this is very peculiar, unusual, and poorly understood language about talking about the benefits of treating Alzheimer's disease. But it's not just about the CDR. In general, translating the language of what it means to treat this disease in research into the language of clinical practice, how I talk to my patients and their family members, is a very frustrating exercise compared to other common, chronic, devastating diseases. Diseases like cancer or heart disease. In those diseases, the conversations are very simply framed around survival, living longer with my cancer because of a therapy that slows down the cancer, living longer with my heart failure because of therapies that help preserve my heart's ability to function, and so on. Frankly, I've decided it's time to think outside the sum of the boxes. Instead, I'm adopting the language of my colleagues in medicine, internal medicine in particular, namely my colleagues in oncology. And I'm focusing instead on thinking about the stages of Alzheimer's disease. The CDR actually does give a stage-based measure, a measure of very mild, moderate, or severe disease. Again, in the quirky nomenclature of the CDR, 0.5, 1, and 2, and 3. 0.5 being very mild, corresponds roughly to MCI, but not precisely, a hot area of debate in the field. 1 meaning mild stage dementia, 2 moderate, 3 severe. Now, there's a lot of data that Eisai published about lecanemab, to their credit, in a paper published promptly upon the presentation of the results at an international meeting, a paper published in the New England Journal of Medicine, along with a supplement. And there are many tables, there are many charts in that report. And one digs through those tables and charts to find this one. This is in the supplement of the research report, meaning an addendum document along with the main research publication. And it's almost at the very end of the supplement. And this is figure S6, S for supplement, figure 6, titled Time to Worsening on the Global CDR Scale. And I pulled for you text from the paper that was published in the New England Journal. And this is very scientific type language that simply says that before they analyzed the data, they specified an exploratory and unadjusted analysis to examine time to worsening on the global CDR. That ranged from 0, 0.5, 1, 2, or 3. And that's what this graph shows. And I'll walk you through it. What this graph shows is that people on lecanemab, the green line, were compared to people on placebo, the black line. And roughly every 3 months over the course of the study, the global CDR was recalculated. And so what this is saying is that if you just follow the placebo line, which is individuals not on drug, that by the end of 18 months, about 32% of the people on placebo, not getting lecanemab, but other drugs like donepezil and rivastigmine, galantamine, etc., as well as good care from their families, that about 32% of them had gone from very mild to mild or mild to moderate dementia. In contrast, you see the green line depicting lecanemab. At the end of 18 months, about 23% had progressed from 0.5 to 1 or 1 to 2. A picture sometimes says 1,000 words. I'll let each of you judge the meaningfulness of that difference between a 24% chance after 18 months of progressing to the next stage of the disease versus a 32% chance of progressing. Is that difference of about 10% worth the risks of the drug, worth the hassles of its infusion, worth all those the cost of the drug? That's for a family to decide after I educate them about this. Now, what's frustrating is this is a result that was an unadjusted analysis, meaning there's a lot of flaws in this, and those flaws are not intentional. They reflect the fact that this kind of analysis was not featured as a primary analysis with all the statistical power that would accompany it. And yet, it fits in the theme across all the data in this study of an effect of the drug greater than placebo upon patients' health and well-being, which is why I'm willing to show it. I think that patients, caregivers, and even policymakers understand stage. If you talk about stage of disease, many people here in this audience probably do talk about the stage where their disease is at right now, and they're concerned about their getting to the next stage of disease. And I think family members, caregivers have the same kind of conversations using the various languages of staging. It's a more coherent language of benefit, I think, than CDR sum of boxes or various metric tests of cognition. It integrates function and cognition. Instead of spilling 1,000 words trying to explain what on earth is the CDR sum of boxes or the ADCS ADL scale, etc., I think this picture does really tell 1,000 words. But talking about staging is a start. I'm also beginning to start to talk like a philosopher of mind, because I take seriously something which I don't think we talk enough about when we talk about what it's like to have Alzheimer's disease or to care for someone with Alzheimer's disease, namely that it is a disease of the mind. Dementia is a derivative from the Latin terms mind and out of mind, dementia, demens. And I routinely ask my patient a fundamental question from the philosophy of mind perception. What is it like to be you? What is it like to be John Smith? I say to my patient, John Smith, or to his caregiver, what do you think it's like to be John Smith? And what I found are very emotional and personal narratives that show me how some people accept their disabilities. If things could stay the way they are, they would be fine, says a spouse to me about her husband's stage of disease. And patients tell me similar stories. I need more time. Right now it's okay, but I'm a little worried about the future. If things could stay the way they are hides a very paradox. In time, even with treatment, things will not be fine. What are those things? Well, patients tell me they resist end-stage thinking. Talk about completing their bucket list is so deeply unhelpful, because once the bucket list is empty, what of life remains? Some caregivers tell me, even early in the stage of their relative's disease, how they wonder sometimes if their relative is still there and what's going on inside. I'm scared, I worry about the future and how to handle it, they tell me. What's utterly maddening is that clinicians like me lack a vocabulary to talk about mind, and to talk about the fears people have about the future impairments in their mind. I can't say to my patients, take lecanemab and you'll be less likely to experience these events that you fear. You'll have a more preserved mind. The best I can do is help them to think about what it's like to have the disease and whether living with the disease like that now is something they'd like to prolong, and have same conversations with their family members. Listen, Alzheimer's disease may be a terminal illness. I'm not quite sure sometimes about that framing. But death of body, death of the entire person, is not what our patients and caregivers fear. The first United States report on Alzheimer's disease, published in 1987, was titled "Losing a Million Minds: Confronting the Tragedy of Alzheimer's Disease." In the decades to follow, we've made fantastic progress measuring the disease with scales like the CDR. But we've made very poor progress in figuring out how to think about and talk about what it's like to have a mind, and a mind damaged by this disease, and to care for that mind. I think we need to more listen to our patients and their caregivers and how they make the measure of their mind and how we can help them do that. Thank you very much. I regret that I will not be at the question and answer session. An unfortunate event in my family has required me to be away today at that family event, but I'm with you in spirit. Thank you very much.